All right. Well, welcome all of you, and thank you for participating in our webinar today called Transforming Episode Accountability Model, What to Know and How to Prepare. We're going to be talking today all about team, and I'm sure that most of you are on the phone today because you are in a geography that was just picked to participate in team. And so I hope that you're coming with some questions to put in the Q&A and with being open to some opportunities for learning and figuring out how to get ready for this model that's going to start in 26. With that said, my name is Michael Wolford. My co-presenter today is Stephen Kitterman, and the two of us are going to go back and forth today on sharing our content. Stephen and I have both been working in Medicare alternative payment models, particularly bundled payments, since they started in earnest in 2012, and so bring a lot of experience to the table today. We obviously are with Forvis Mazars. Forvis Mazars is a recently created entity combining Forvis and Mazars earlier this summer, and today is a top 10 accounting firm in the United States with a global presence. Our healthcare consulting practice specifically is constantly growing, has a very big value-based care presence, but also works in strategy and finance, reimbursement, performance improvement, and payer services. Hopefully give you this little 30-second explanation of Forvis Mazars and our healthcare consulting team to avoid Google search during our presentation. Today's learning objectives are going to very closely follow the agenda, which is to give you the backstory on Medicare's value-based care strategies and their current progress toward APMs and goals. We're going to dig in detail to the team model, the timeline, who's required to participate, as many details as we can fit into a 1-hour CPE session. And then finally, for those of you that have been selected to participate in team, we're going to talk about what's required, what are best practices, what's the new normal going to look like in 26, and how you bridge the gap between today and August of 24 to be ready in January of 26. And so that's our agenda today. Overview of episodes of care, digging into detail on team. We probably won't use the full version of the name, which is Transforming Episode Accountability Model. We're simply going to use the word team, and then how organizations can prepare to participate in team. All right, so the overview. Episodes of care have been around in Medicare land for a very long time. Medicare, when we say Medicare, we're both talking about CMS and one of its divisions called the Center for Medicare and Medicaid Innovation, created through the Affordable Care Act, that has the legislated authority to test new alternative payment models. And they've dug in on how they can create a comprehensive specialty strategy that focuses on the 4 elements you see on the left side. Now, I want to separate this and the specialty strategy from its primary care strategy. And when they say specialty strategy, they're primarily talking about episodes of care. And the reason why they're really focused on this, not only does their research suggest that there is opportunity to provide more efficient care, there's also an opportunity to provide less fragmented care and a better care experience for Medicare beneficiaries. So as I mentioned, the difference between specialty strategy and primary care strategy really fall into the 2 different primary types of alternative payment models that we've seen proliferate since the Affordable Care Act started in 2010. The first kind, probably the more popular kind, is primary care, population management strategies, things like Medicare shared savings programs, ACOs. There are all sorts of different types of ACOs, REACH, Flex, et cetera. Lots of different ACO type programs that primarily deal with prevention and management of diseases and chronic care management, trying to lower overall expenditures over a year, over a long period of time for a set population. And the opposite side of the coin are episodes of care. The two most popular predecessors to our program that we're talking about today, TEAM, are CJR, which stands for Comprehensive Care for Joint Replacement. That was a mandatory joint replacement bundled payment that started about 2015 and runs through the end of this year. And there were also two voluntary programs, bundled payments for care improvement and its successor, bundled payments for care improvement advanced, which is still in place today through the end of next calendar year. And this is primarily looking at reduction in post-acute excessive expenditures, readmissions, and managing the recovery of patients after surgeries or acute hospitalization. Both super important, but both have different strategies in Medicare's eyes and in the eyes of the participants, like hospitals and physician practices that are doing them every day. So in an episode of care, there are all sorts of different definitions of what things are included. In general, for the purposes of TEAM and for what Medicare thinks about when they think about episodes of care, we're talking about total cost of care during a timeline, which in this instance and in many instances includes the initial hospitalization or the initial surgery stay if it's in the outpatient hospital outpatient department, plus a duration of time after the patient leaves that initial anchor stay, whether it's outpatient surgery or inpatient hospitalization. Almost everything is included. You see on the right side things like the initial hospitalization at the top, post-acute care services at about 2 o'clock on the dial, readmissions, physician services, Part B drugs, DME, labs, flu shots, all sorts of things get included here. Services that span beyond the episode, start during and extend beyond, are prorated, and the revenue cycle isn't disrupted. There is no change to the revenue cycle. All of the providers and the provider types that you see on the right side continue to provide services and bill Medicare and get paid. There's no modifiers or additional billing requirements. And practically everything is included. Our research suggests that 99% of claims value and claims cost are included in episodes like this when they meet the initial hospitalization or surgery requirements. So I talked a little bit about the couple of big predecessor programs, but I do want to lay out that this has been a program, TEAM is a program long in the making. Many of you have heard of the ACE demonstration, which started in 2010, that actually did save some money per episode. That moved into the bundled payments for care improvement model, which was very popular, started in about late 13 and into 14 and ran through the end of 18, which then, I'm skipping over CJR, BPCI Advanced was the successor model to BPCI and is still in place today. There have been a couple of different iterations and changes that Medicare's made to BPCI Advanced. You also hear us call that BIPSI. That's the wordification of the acronym BPCI, BIPSI Advanced. That program is still in place today and has more than 100 hospitals, more than 100 physician practices choosing to do that program voluntarily. Now, CJR in between there is I mentioned a 90-day episode of care model in selected geographies for hip and knee replacements. This program is going to end at the end of this calendar year, and many would suggest that TEAM is essentially kind of a combination and modification of both CJR and BIPSI Advanced. Suffice it to say, there's been a lot of testing that's occurred up to this point. There have also been a lot of false starts, things like the episode payment models, EPM, that was announced in late 16 and was eventually canceled. There's the radiation oncology model that was announced but eventually canceled. None of those had the same type of momentum that TEAM has today and the same type of research history and bipartisan support. brings us to our first polling question. Does your organization participate in any CMS alternative payment models? We're going to leave this polling question open for a minute. And the first option is yes, we participate in a combination of mandatory and voluntary models. Second option is yes, we only participate in what we have to participate in. Third option, option C, is we have not been yet mandated to participate, and so therefore we're only participating in voluntary programs. Fourth option, option D, is no, we are not participating in any alternative payment models. We're going to leave this open for about 10 more seconds to make sure everybody has an opportunity to respond to this first poll. And we'll go ahead and close the polling question and look at the results. A lot of folks have not participated in CMS alternative payment models. You see 56% have not, 23% are participating in both mandatory and voluntary programs. Thank you all for responding to that polling question. I'm going to turn it over now to my colleague, Stephen Kitterman, with whom I've worked for a long time and knows an awful lot about bundled payments. Stephen, take it away.
Thanks a lot, Michael. Yeah, so you see here just some of the benefits of participating in these episodes of care model, whether you're a patient, a provider, or a payer. And this is kind of what CMS views as a mechanism to help kind of achieve the triple aim across this patient population. So you can kind of read through the bullets there. I won't read them all, but for patients, the goal is obviously improved experience and clinical outcomes. The fragmented nature of the care of the surgical handoff to primary care is a clear driver of team. And then, of course, the providers, there is some upside here. So when we talk about the two-sided risk nature of this model in a second, you're going to see that there is some opportunity for providers who can become more efficient or stay as efficient as they have historically to share in some dollars and that type of thing. Also creating relationships with downstream providers and that type of thing. And then, of course, for payers, this is more of a kind of a revenue stream diversification. For CMS, they have a number in mind of dollars they want to save, both through kind of trends in payments and utilization, but also in the amount that they think that they're going to receive back from the two-sided risk of providers in this model. So we're going to talk a little bit more about that as well. So let's maybe get into some specifics of team rather than generally episodes of care. So first of all, Michael talked about it, mandatory for selected acute care hospitals, the goals of improving quality, addressing fragmented care, and then of course, as part of many of these new models, you've got improving health equity and access to high quality care for people in underserved areas. You're going to see in this model that underserved areas comes into play a little bit more as we're looking at more rural geographies being selected, more safety net and oversampling there. So they are certainly kind of doubling down on those goals for team. So a couple of things about team. We had a question a little earlier in the webinar. Hey, what are the chances CMS backs out of this like they did the episode payment model? And I think we would say very low because this has been building for about almost 2 or 3 years. And they've done some due diligence, and they meaning CMS and the Innovation Center, to look at episodes of care in their strategic refresh. So they did that back in 2021. Then in June 22, they came out with a blog post openly considering, hey, mandatory bundles may be the way of the future versus voluntary bundles. At that time, right after that in February, they reopened the voluntary bundle model, hoping to build some momentum around episodes of care towards potentially announcing a mandatory bundle model right after the voluntary BPCIA is done. In July, they requested feedback. So they got 157 comments back, and essentially they noted a lot of things about that. Number one, hey, maybe 30-day bundles are a different view than 90-day bundles, and that's what we should test in the future. Right after that, they start giving bundle data or episodes of care. They called it shadow bundle data to other types of alternative payment models. So if you were participating in MSSP, they found that 95% of those MSSP providers wanted data on episodes of care. So they pushed that out. That's still going to those participants on a monthly basis and can have a lot of valuable information in them. April turns around, 2024, they announced the proposed rule with a number of geographies, and they say they're going to pick 25% of those nationally. And then in August, we got the finalized rule with minimal changes. With minimal changes from the proposed rule, they did leave a couple of things out for additional rulemaking in terms of some low volume policies and things like that. But ultimately, outside of some additional protection for rural providers and a few changes for the risk adjustment, not a ton changed from proposed to final rule. All right, so if we were just looking at generally speaking, what are the 12 things to know about TEAM if you want to have a conversation about it, and kind of look at what may be required as you think about performing in this model. Number one, it's going to run 5 years. So January 1, 2026 did get finalized, and it will run through 2030. You will be required to participate if you were selected in a CBSA that was in that list in the final rule, and we'll go over that in a second, because there's some different ways of thinking about things from a am I in basis versus what they've done in the past, and we'll talk about that. To keep the momentum of folks that have voluntarily or mandatorily had to test these models before and have put processes in place, teams in place to do this, they don't want to lose momentum in that. And so they are allowing those providers that are not in a selected geography to participate in the model if they want to opt in. Now, that opt-in is a one-time opt-in. You are in for 5 years if you determine that you want to do it, and you do have to be a participant in one of these models when they end. So for CJR, that's going to be this year at the end of 2024. For the BPCIA advanced model, that's going to be at the end of 2025. This is the surgical bundle that we're talking about is an inpatient stay, and then the 30 days after that surgery. So when you think about that, that's basically, as Michael said, all Part A and Part B, but the revenue cycle is not disrupted. So while the hospital is going to kind of be the risk bearer, if you will, everyone will still get paid their fee-for-service dollars. There's just going to be a retrospective reconciliation once a year to look at aggregate spending versus aggregate target to determine whether a provider would have to write Medicare a check or they would receive a check in a two-sided risk year. And those don't start right away, which is what you see in that next kind of shaded bucket, which is there's graduated risk through 3 participant tracks, starting with everyone can start 0% downside for the first year. So no downside risk for the first year. And then some providers will go to 5% risk, some providers will go to 20% risk, and some will be able to stay at 0% risk for another couple of years. So we'll go through the specifics of that because there are some hospital classifications that are a part of that. I will mention here that critical access is not included in this. So a critical access hospital cannot initiate a TEAM episode as part of this program. There's 5 surgical episode groups, and we'll talk about those. This is not a cherry pick, hey, I'd like to do this episode and not this one. If you're selected, you are on the hook for all 5 episode groups, and a couple of those have inpatient and HOPD outpatient considerations as well. Question we get a lot is, how are they going to set our benchmark? How are they going to set our target price? What are we going to be compared to? First of all, that's going to start at the regional level. So the census region level, which is usually a group of states in your area. That's where the target price is going to start for a particular DRG. So if you have a hip fracture DRG 522 in the South Atlantic region, you're going to start with the same target price as others in the region. That is then going to get adjusted for certain things. That's going to get adjusted for certain hospital characteristics, and it's going to get adjusted for certain patient characteristics in the ways of comorbid conditions, dual eligibility, age, all those types of things. So while you do start at a uniform target price within a DRG or HCPCS within your region, you will eventually get to a patient-specific target price based on those elements. There is overlap allowed with ACOs and most other types of alternative payment models. So that is something to coordinate care. A big goal of this is to look at the handoff from surgical episodes to the primary care environment. So they are saying, yes, if your patient is attributed to an ACO, it can still start a team episode and can be reconciled in both models with no recoupment between the two. So it's not like if you were to underspend in team against your target price and you received a reconciliation payment, they're not going to take that back in the context of the MSSP, if you will. All right, there is some quality in this. We'll talk about that. And then there are some requirements that Michael's going to talk about at the end of this. But one that is new is the inclusion of a referral to primary care in your discharge planning. So there's a couple of requirements. Most of the requirements are going to come in line with some reporting that you probably already do through your inpatient quality reporting, through hacks, all those types of things. But naturally, there will be a couple of things that you'll need to operationalize as part of this. All right, we're going to talk about a lot of these things. These were the primary main changes from proposed to final rule. And in that, I'm just going to pick out a couple of these. First of all, the risk of those track 2, those rural providers, did go down. So it used to be 10%. Now they're saying it's going to be 5%. So that was an increased protection for rural. And then safety net providers do get some upside only years. The other thing that I would say, the other two things that I would say were big changes was an update to the discount factors. So originally CMS said that these would be 3% discount factors. And now they went back and said, hey, 3% was based on 90-day episodes. That's probably a little too harsh for a 30-day episode and having to reduce spend 3% below a benchmark price. So what you're going to see now is in cabbage and major bowel, they're only going to take a 1.5% discount off that target price. And for the orthopedic ones and spinal fusions, they're going to take a 2% discount. Last thing, the rural hospital definition. So before, in CJR and some other predecessor models, if you reclassed to rural for wage index purposes, you were considered rural. That's changed in this, that it's going to be based on where you are geographically, and the reclass to rural for wage index purposes does not matter. So they're going to look at your primary address of your Medicare CCN number, your certification number, to see if you would be included in a CBSA for participation. When they do that, if that is in a urban area, then you're likely going to have the 20% downside risk, and otherwise, if you're truly rural, you'll get the 5% reduced risk. All right, I think we talked about this, and I'll just touch on it really quick. But again, the risk bearer is going to be the hospital that does the triggering inpatient or outpatient procedure. If, say that patient went home after that, or had a skilled nursing visit and then was sent home with home health, all those dollars are going to accumulate as CMS or Medicare reimburses those individual providers. They're going to add all those episode costs up. They're going to compare them to that target price, which again starts at your region, goes down to a patient level, and then they're going to take the difference of that. And if that's the only patient you had, that would cause a repayment or a payment to you as part of the model, subject to those risk corridors. Just really quick, we talked about 25% of the CBSAs were selected in this. So that's 188 of an eligible 803 CBSAs were selected for team. That's by our estimates, looking at surgical volumes and hospitals that would impact, it's more than 700 hospitals nationwide, over 200,000 cases, and CMS predicts that they're going to save $481 million as part of this. So this is not a budget neutral type model for them. This is, they expect to get more dollars back in repayments than they would pay out in reconciliation payments to hospitals, and they expect to save money from a historical period. And all of that added up comes to that $481 million as a part of that. All right, I think that brings us to a polling question. So based on what you know about the CBSAs that were selected, which I don't think that there's a list publicly yet, except for in the final rule. So you probably had to go to a PDF and download the tables and that kind of thing. But do you believe that your organization has one or more hospitals that would be required to participate in team because of the geographic location in the CBSA? So again, this is physical location, not necessarily whether you reclass into a rural CBSA for purposes of wage index, but physical location. Would you be in a team geography? And we'll leave that open for a couple of more seconds just to see kind of how that shakes out for our participants today. All right, unsure, 44%. That's not abnormal. There's a lot of nuances to this. No, 37%, and yes, 18, or right at almost 20% of the participants today. That's great. All right, we talked about the opt-in. Here's all I'll say about the opt-in for those of you that aren't in one of those CBSAs, but you have done the comprehensive joint replacement or the BPCI advanced model, you're in them now. That opt-in period is going to come quicker than you know it. It's going to come January 2025. And you're going to have to submit an opt-in voluntary letter, and you are opting in for 5 years, and there's no opt-out after that. So understanding your position in these models, understanding your position in this model, which is a little different than what you've done in BPCI and CJR, target pricing different, model episode structure, different timing, all that kind of thing. That's going to be imperative as you think about whether this makes sense from a opt-in perspective. All right, here's what's included. So you've got your lower extremity joint replacements. Those are your hip and your knee replacements, your ankle replacements. Those can be inpatient or outpatient. No ASC volume is included here. It's only HOPD or in the inpatient setting. You can see the billing codes that are included there. Then you're going to have your hip pinnings, your surgical hip and femur fractures. That's one where we know that there's a lot of post-acute care associated with it. Then you bring in CABG. So the CV surgery service line is now involved. Spinal fusion, that's the other one that's going to be inpatient and outpatient as part of this. Again, HOPD, not ASCs. And then we bring in kind of a gen surge in the major bowel procedure. These were picked because of their volume nationwide, high volume surgeries with opportunity to reduce expenditures across a 30-day episode. Had a couple of questions about target price. Really quickly, let me explain how that's going to work. Again, you'll start with a regional target price. There's going to be those patient and hospital specific adjustments. There'll be trend factors. There's always trend factors in these to make sure that you're staying with the pace of change of what's happening nationally and regionally. And then there'll be that discount as part of the target price. So all of those things are going to go into your target price as part of this. Now, when you think about that, really quickly about what's included in kind of the patient-specific target pricing. So this changed with the final rule. We still have age, HCC count, social risk, hospital bed size. Those things are going to go into the risk adjustment model, and a lot of those were proposed. But what wasn't proposed was looking at individual HCCs that are specific to a particular episode group that are captured in a pre-episode period leading up to that trigger event. So a little different from a catchment period perspective in that these are probably going to have to be done 90 days prior. There is some talk of 180 days. The notice of proposed rulemaking did say 90, but individual HCCs are going to have a different impact each on the target price of a particular patient, and they're different across these episode groups. So just wanted to point that out as we think about what are the ways in which our target price raises and lowers as part of this model. So we talked about what's included in the spend. We talked about what's included in the target. The difference in those is obviously the reconciliation or the repayment amount. So what are the guardrails on the repayment amounts? So again, team is going to have graduated risk through different participation tracks. All participants can start year one with upside only, and your stop gain will be 10% of your program size. And when I say program size, essentially what I'm talking about is you're going to get a benchmark price and you're going to have volume. Your program size is your volume times the benchmark price of those episodes. So as you think about how much exposure you may have, if you think about how much upside you might have, that's kind of the calculation to get to those corridors. Now, once the first year is over and the upside of risk is over, that's when providers are going to kind of separate. So number one, safety net hospitals are going to get to stay in upside risk only for another 2 years. And then they're going to go very minimal downside risk or upside and downside with 5% in years 4 and 5. The rural hospitals, the sole community hospitals, there's some other designations for those folks. They're going to move to year 2. They're going to move to 5% stop gain and loss as part of the model, and can stay there into the end of the model. Everyone else is going to move into 20% upside downside. Now, those folks that have the lower risk modules, they can move into the riskier one at any time. In fact, CMS has said in the final rule, they're going to actually put you in the more risky one unless you notify them that you want the reduced risk model. And that's going to be kind of an annual delegation or election, if you will. So some important things there as you think about what bucket you fall in terms of risk tracks for the model over time. All right, here we are at another polling question. Does your organization have experience participating in an alternative payment model with downside risk? So this could be on both sides of that downside risk. This could be kind of what Michael talked about before on the primary care side with Medicare shared savings programs or ACO REACH and that type of thing. It could also be in the BPCI advanced model or the CJR model, those that had downside risk and nominal risk corridors. So if you participated in one of those or you're unsure, if we could leave this open for a couple of more seconds, and then we'll look at what the answer is. All right, so 26% saying yes, 35% saying no, they haven't, and 38% are unsure. So in the sense that you haven't, and you're in that 35%, and you were in the CBSAs that said, yes, I'm a part of this model, there'll be some kind of ramp up things that we probably would suggest to do as you think about going towards January 1, 2025. Real quick, won't spend a ton of time on this, but these are the participants that get the reduced risk. So if you're a safety net hospital, you do get the 3 years of upside only. That is a little bit different definition than other definitions. This is consistent with some of the other alternative payment model definitions, but nevertheless, that you can qualify a couple of ways for that. And then rural is going to be, again, you're located in a rural area or rural census tract versus reclassing. And then you've got a couple of other ways to qualify for the reduced risk as well. Lastly, I want to touch on quality measures before I throw it back to Michael. A couple of things about the quality measures. You'll notice hybrid all-cause readmission measured. You notice PSI 90, lower extremity patient reported outcomes. CMS has hopefully tried to reduce the administrative burden of participating in this model, and that's why you see some IQR measures there. That's why you see some HAC measures there. And for purposes of this, these measures are going to be what goes into a composite quality score that eventually acts as a multiplier on your reconciliation payment amount. So just to give you an idea how that works, you can see a couple of different examples down there at the bottom of how it works on the negative side if you were to have to repay Medicare. If you have to repay Medicare and you perform well in quality, you'll have to repay them a little less. If you have positive financial reconciliation, it's going to act as a multiplier to that for 10% of that if you're in track 3. So if you see in that calculation, if you beat your target by $100,000 and we're set to get a $100,000 check from CMS as part of this model, they're going to look at 10% of that, or $10,000. They're going to look at your composite quality score, and then they're going to give you a portion of that 10% based on how well you did. So if you were the worst in the country in quality, when they compare you in percentiles to these other providers, you would receive $90,000. You would not get any of that $10,000 back, but that's probably unlikely to happen. And therefore, you would get a portion of that back as part of this. All right, so I think next we're going to go into actually preparing. Those are the facts around team. You know, there's a couple of things still out there like low volume policy that we'll know over the next year and that type of thing. But Michael, maybe let's talk about preparing to participate in the model.
Yeah, thanks, Stephen. A really good job digging into the details here. I'm harkening back to one of the more recent polling questions that Stephen just asked, which was, are you in a mandated geography? And a lot of you don't know if you are, which is, like he said, very normal. If it's a possibility or you are, there is kind of participation readiness activities we're going to walk through, which are listed right here, right? Figure out if you're in today would be kind of the first step. And then the second step being, if you are forced into team, how are you performing today? Step 2, based on how you're performing, how can you do better? If you're currently in a loss position, you know, like looking back in time, if you would have been in a payback position to Medicare, how can you get from the red to the black? If you're already in the black, how can you get even better and make more money in this program? There's strategies available. There's waivers available. There's all sorts of different ways to improve performance, but you have to know where performance is today. And lastly, once the program starts in 26, there's a continual plan, do, study, act cycle that we think should happen every month, looking at the past and the current activities. What can we do different to do better? So those are all great ideas. But here's why we think those great ideas are worth time. We mentioned earlier, there's actually a question come in through our Q&A. how likely is this mandatory thing to actually stick? And the answer is, Stephen gave it, very likely, both because they've been planting seeds for this for 3 years and because there's been a lot of money invested across a lot of providers to create infrastructure around episodes of care, and Medicare being a primary payer that kind of funds that. So they are been very clear that there is not a lot of wiggle room to cancel this program. Mandatory means mandatory. We don't see any reason to not prepare. Second, Medicare is not going to provide you any data until November of 2025. November is an approximate timeline. So today we're August 24. We're talking about not getting any data from Medicare for 15 months. That's a long time to just simply sit and wait when you've got an upside-only year that you could be taking advantage of getting ready for. Third, pace of change matters for several reasons, but first because this program is target price based on how you do compared to a regional benchmark. And so the quicker you improve, the more likely you are to succeed. And here's the last one. Medicare is expected to make almost $500 million on this program over its 5-year run. That includes the first year where they're only paying out gains to providers. So let me be very clear. This is not what I would consider a Robin Hood program where they take money away from poor performers and give it to good performers, and Medicare is just a pass-through entity. That is not the case. Medicare is the house, right? They're taking money to fund the Medicare Trust Fund to the tune of almost $500 million over 5 years. And so we know there will be more hospitals that pay money back than those that get money from Medicare. So with that said, how to prepare? This is how we're recommending folks get ready, right? We mentioned this already. Figure out where you exist today on TEAM. TEAM has some unique specifications. So relying on bundled payments for care improvement advanced or CJR or ACO performance, that's going to get you in the ballpark, but it's not precise. Part 2, figure out what you need to do in 25 to be ready for 26, and then in 26, do that plan, do, study, act with the monthly claims data that's going to be coming your way. These are things that Forvis Mazars helps with. We're respecting the CPE nature of this webinar, so we're not going to talk about what Forvis Mazars does to support, but we do support these activities. Here's an example of the current state assessment type stuff, right? So there were a couple polling questions like, how are they going to account for the fact that we had to pay nurses more, or the fact that that internal costs, so joints, the actual joint hardware, like how are they going to account for that in our target price? And what you're going to see here is that that's not part of the calculation. What's part of the calculation is you have a target price, and you are expected to manage to that target price or make the payback. What you see on the left side here is that calculating the target price and the average episode expenditure. When we say expenditure, we mean what Medicare pays to all the different providers. And looking at that in the past, right? Figuring out what would we, says the participant, have owed back or have received if this program had been in place, for instance, in 21, 2, and 3. On the right side, where do you have pockets of these surgeries that are profitable? This example that we pulled together didn't have any, but suffice to say, there may be some pockets of positive performance where you can say, hey, perhaps one surgery type doesn't need as much attention as another surgery type. Other KPIs here: post-acute utilization, readmission rates, SNF length of stay. Those are big issues. Even where patients have their procedure, whether it's HOPD or inpatient for joint replacements and spinal fusion, are going to be big drivers of success in this program. We also mentioned that beyond being prepared to take advantage of the money that's out there, they're also just straight requirements, right? Think of this like Medicare's conditions for participation for 700 hospitals are going to get a little bigger, a little higher, a little bigger burden come 26. Now, some of these that you see on the left are common among alternative payment models today. Things like beneficiary notification that exists in every Medicare program in one way or another, but it is simply a requirement. There's no bonus if you do it. There's no explicit penalty if you don't, but they will audit and they will want to know if you've done those activities. Stephen mentioned the referral to primary care. Think of it as like a warm handoff before the patient leaves the four walls of the anchor place, the hospital or the HOPD. Health-related social needs screening is a big deal. Right? We know from research and common sense that when patients have health-related social needs, they tend to not rehab as well. They tend to not be as well and perform as well, both in life and in programs like this. So health-related social needs screening is hardwired in as an expectation. And lastly, lower extremity joint replacement patient-reported outcomes is becoming a little bit more common in other programs. You see some voluntary reporting on the far right side that could become required in future years, but these are voluntary reporting opportunities today on the far right side. I just want to reiterate one more time, though, that the things starting in performance year one, which is calendar year 26, are not optional. And these are requirements for all participating hospitals in TEAM. So if those are required, what are the other options, right? These are strategies that we see that organizations are considering, right? Things like aligning with surgeons so that the surgeons are tracking with your results, and in many instances are earning gain share or in a financial arrangement with the hospital to win when the hospital wins, right? There's a whole section of the final rule dedicated to provider alignment and gain sharing and financial arrangements. There are waivers available, just like there are for many Medicare programs. Many of you on this call already said we're doing value-based care initiatives today, and there will be some type of Venn diagram overlap to the things that you're doing today versus the things that TEAM will require or may benefit from. We hear a lot about post-acute alignment. You still have to respect beneficiary choice. Beneficiaries get full choice in their care. You can't tell a patient you can't go to this post-acute provider or see this provider. But there are ways that have been very common over the last 10 years to create formal and informal networks with post-acute providers and other providers that are well aligned and will take better coordinated care of these patients. There's also a big section here on decarbonization that is an option that we haven't heard a lot of folks be super interested in, but it is certainly out there that Medicare is interested in adding here to this model. All right, so next steps. I'm just simply reiterating what we've talked about here before. Step one, evaluate where you are today with precision. I'm adding the term with precision because there's no neutral zone in this program. If you overspend by $1, you owe back $1. If you underspend by $1, you get it, right? There is no neutral zone like there are in a lot of other programs. And so being precise with current performance matters a lot. Part two, we know that value-based care capabilities took a back seat during the public health emergency, but we also know that they are becoming more of a front burner issue. And so building out those value-based capabilities and deploying them on TEAM episodes is part two. And then figuring out who's the team, no pun intended, who is the group of people that's going to work on TEAM so that we can be constantly iterating and testing what do we need to do to do better in this program. I'm going to leave you with these last two quotes here on the right side. Medicare has been very open for the last couple of years with its goal of having every single Medicare beneficiary in an accountable care relationship by 2030. And this is one major step toward that goal. This is also not the last step in mandating performance and participation toward that pretty lofty moonshot goal. And if you feel like, hey, we don't have these capabilities, you're not alone. Our research, Forbes Mazars research, suggests fewer than 30% of healthcare executives believe that they can operate value-based care in line with where they think value-based care ought to be as part of their future. So there is a closing of the gap, right? The future will command this. And if today we're currently not performing at that level, most people would say that that's true. So if anything that we've shared today kind of rings a bell, the last polling question is going to come up here in just a second, asking, hey, do you feel like you need more information? Whether that's, hey, I want you to repeat this presentation for my colleagues. Great, please, yes, contact me. If you want to find out, hey, are we included in this model? Yes, please contact me. If you want to find out, like, how are we performing? How many episodes would we have had? What is our program size? What's our total potential risk? Yes, please contact me. If what we said today answered every question you could possibly ask, click no, not at this time. With that said, we're going to give everybody about another 10 seconds to answer this last polling question. And we are going to jump into any Q&A. Stephen, I know there was a Q&A here that that I wanted to answer, and it was about, is my hospital included? And with lots and lots of people on this phone call, it's tough to get into the individual hospitals. They also didn't call out specific hospitals in the rule. They called out CBSAs, which are either metropolitan or micropolitan statistical areas. And you've got to figure out if your hospital's primary physical address is in those CBSAs defined by counties. Again, if you didn't click yes, just give us a call. We can help you figure out if that's the case. Stephen, are there any Q&As that you want to answer here?
Yeah, I think we've answered a lot of them as we've gone. Maybe one that we got is around, when are we going to get these regional target prices and things like that from CMS for that January 1 start?
It's likely that those won't come until November of 25. With that said, that's one of the reasons why it's one of the ways that Forbes Mazars is helping folks is to calculate those before Medicare gives it to them, and at the same time calculating what performance would have been against those. So if you're waiting by the mailbox for Medicare to send those to you, you're waiting a long time. And for that reason, we think it's really important that you seek information elsewhere.
Yeah, that's a good one. I think the other thing that I'm seeing as a theme in our questions is around maybe smaller rural providers. So maybe they don't do all of these types of surgeries. Maybe they have really low volume. But maybe for that one, is there an opt-out if you're low volume at this time? And then what if you didn't do all the surgeries? What would that mean? What if you didn't have any major bowel surgeries or spinal fusions, but you had joint replacements and that type of thing?
Yeah, I saw a couple of those questions too, Stephen. So in those instances, Medicare has said, and I almost paraphrase here, we know there is a lot of questions about low volume hospitals and them asking, should we still be required to participate if we don't have that many cases? And they've said, you're right, that's a policy we need to create, but we haven't created it yet. If past is prologue, then low volume to Medicare means like 10 total cases across the whole hospital for the year that would qualify for TEAM, right? So we're talking about a very low volume number, right? Hospitals with 50, 100 cases are likely going to still be mandated to participate. But again, let's hold off on knowing for sure what that is. If, though, the other example that you said, hey, we've got maybe a handful of joint replacement cases, but we don't do CABG. We hear that a lot. Then you simply would not be getting any gain or loss for not doing any CABG procedures. You just effectively be in team for your joint replacements. So it really follows individual patients and what their surgery type was. And if you're not doing certain surgery types, then those types of patients would obviously not be included because you're not doing those procedures.
Great. Maybe one more we had here at the very end. Did CMS define what is a safety net hospital? And I can take that one. The answer is yes. For purposes of this particular model, they're going to look and make sure if you're in the 75th percentile of a proportion of Medicare beneficiaries at all the IPPS hospitals in the baseline period that have either dually eligible beneficiaries or beneficiaries that received a low-income Part D subsidies. So you can qualify in either one of those, which, as you think about that definition and being in the 75th percentile, that's a little bit different than the way they've defined it for some of the other programs. So we expect that when they release a list of hospitals, whenever that is, maybe preliminary, maybe final later in 2025, they will say, hey, these particular providers qualify for lower risk because of safety net or rural designation or something like that.
We'll say there were more questions than we had time to answer today. Thank you all for participating. Those that did submit questions, we'll respond to you individually here on email in the next couple of days with responses to those questions. With that said, we are going to close today with a video. Thank you all for your time. Stephen, thank you for presenting with me here today. Have a wonderful day.